In this video, we are going to address racial disparities in COVID infection and outcomes, and look at the racial and ethnic breakdown of the trial participants. We think it's important to start this topic with an acknowledgement that the medical field, and research in particular, have done some pretty horrific things to Black Americans and people of color in general. Most of us have probably heard about the Tuskegee Syphilis Study, which started in 1932. The study aimed to learn about the natural course of untreated syphilis and enrolled about 400 Black men from Alabama who all had syphilis at the beginning of the study. There were lots of ethical issues with this study from the beginning, with misleading promises about receiving free treatment and without truly obtaining informed consent from the participants. At the beginning of the study, there was no treatment for syphilis, but in the 1940s, when penicillin was discovered as a safe treatment and cure for syphilis, and in the 1950s, when it was widely available, these men were not told there was a treatment option, and there's evidence that the researchers actually sought to prevent their treatment. In 1972, the experiment was halted, with only 74 of these men still alive. Many of them had died from advanced syphilis. Another commonly talked about example of unethical treatment of Black people by scientists involved Henrietta Lack. She was an African-American woman from Virginia who had cervical cancer. Her tumor was biopsied at Johns Hopkins in the 1950s, and the cells were cultured and used to create a cell line that is still used today. Henrietta Lack never consented to have her cell line used for research. She was never compensated for their use, and her family medical history has been published without consent of her or her family. These are two more public cases and examples, but there are many more individual examples in research and in medical care where people of color's rights are violated. The medical community has violated the trust in this population. And a healthcare pandemic only serves to magnify the racial and ethnic disparities in access to care, trust of medical and science community, quality of care, and outcomes. In the next few images, we're going to use this color coding, where the blue-green color means that Black Americans have a disproportionately lower proportion of either deaths or cases compared to their proportion in the population, or the orange-red color means that Black Americans have a disproportionately higher proportion. If we look at this abstract map of the United States, we see that almost all states are reporting orange, or disproportionately higher rates of COVID among Black Americans compared to their proportion of the population. This disproportionate disease burden carries over to COVID deaths, where again, Black Americans die from COVID at a disproportionately higher rate. Black Americans are 1.4 times more likely to test positive to COVID and 2.8 times more likely to die of COVID compared to their white counterparts. These same racial disparities are seen among all people of color. If we look at the age-adjusted COVID deaths per 100,000 people, the rates are highest among Black and Indigenous people, followed by Pacific Islanders, Latinos, and Asians. The lowest death rates are among whites. There are many reasons these disparities exist, ranging from differences in access and barriers to healthcare, comorbidities, and systemic racism within healthcare. Especially because of these disproportionately negative outcomes of COVID among people of color, it is critical that we provide honest and thorough information about the COVID vaccines so that everyone can decide for themselves the best course to prevent infection. Let's jump into the vaccine trials and see the racial and ethnic breakdown of participants enrolled to study the Moderna and Pfizer vaccines. The NIH and FDA have guidelines for inclusion of racial and ethnically diverse study populations. Phase 3 trials aim to enroll a participant population that mirrors the general population, and both Moderna and Pfizer did a pretty good job of this. If we look at the blue column of this table, this is the percent of people in each racial or ethnic group in the general U.S. population. The middle column gives you the percent of people of each racial or ethnic group in the Moderna trial, and the last column gives the information about the Pfizer trial. As you can see, these trials worked hard to enroll people of color and to get their study populations as close to representative as they could. Both studies report high efficacy when examined by racial and ethnic category, and no adverse events disproportionately reported in specific racial or ethnic groups. Tyra Williams, director of nursing at Bethesda North Hospital, describes this best when she explains why she decided to take the COVID-19 vaccine. She says as a nurse, she feels it's her obligation to her peers and patients to get the vaccination to protect them. Being an African American, she wants to set the example for her community that it's okay to take the vaccination. Tyra says that she feels that African Americans are at a disadvantage when it comes to access to healthcare, and there are other factors that plague the African American community and make African Americans at a greater risk of getting COVID and dying from COVID, and that's why it's so important to take the vaccine.